Okay, so hi, good afternoon, everyone. I think we are live. You all can hear me and see me very, very clearly. Okay, so today I'm here with the MCQs of. Okay, so hi, good afternoon, everyone. Okay, so I'm here today with the MCQ recalls from the FMGE examination that we had a couple of days back. So let me just, okay. Yeah. So I think everything is good, going fine. Yeah. Okay, let me start with that. So guys, this time in the FMG exam, we again had some simple basic questions. So if you have been through, if you have been reading the basic concepts, and if you have been reading the conceptual things, the subjects conceptually. So basics were the main content of this question also. No hi-fi thing, all the basic simple things, right? So, hi Jabbar, how are you? So let's see the questions that we had this time. So I am Dr. Sushil, your faculty of orthopedics at DBMCI, and those who have been connected with me, they pretty much know, me already. So let's see the questions that we had this time in our FMG examination, right? Okay, so okay, okay. Okay. Okay, so the first question that I have been able to recall, my team has been able to recall is the which type of joint is present at the arrow marked joint shown in the X-ray. So basically, this image is marking something around the pubic areas, the pubic symphysis areas, and by the knowledge of your anatomy, I would not say that that's a question of orthopedics to be discussed here, but yes, when you talk about the joints, basically different types of joints, then you learn that this pubic symphysis, which has been a repeat question basically, hi Noor, good afternoon. So this is basically your secondary cartilaginous joints, right? That is your basic knowledge of anatomy. So if you have seen the skeleton, if you have seen the skeleton system that I have shared already on some of the social media platform, it simply highlights the type of joint that a skeleton is having at some of the areas, right? So that was clearly mentioned there, that secondary cartilaginous joint. Very good. Apoptosis, Alia has already answered that very, very correctly. So absolutely true, absolutely right, that it was secondary cartilaginous joint. So I think those who have been able to remember the images in their mind, they would have been easily able to mark it out. That was secondary cartilaginous joint. Okay. Second was a patient having history of leprosy has presented with the deformity as shown in the image. Which nerve is involved in this case? Can you tell me that? Can you tell me which nerve is involved in these patients? So here the patient image showing is something, the finger is bent, the two fingers of the medial side, the little finger and the ring finger, they are bent, and some partial you can see, movement. The rest of the three seems to be all right. Okay, so what do you think it is? A, ulnar nerve is gone. So why do you say it is ulnar nerve which is gone? So see, there might be a confusion. Some of the students told me, sir, we marked the median nerve injury. I asked, why you marked median nerve injury? They said, sir, the finger, the index finger was straight. Pointing index sign was there. So please understand that what is the basic difference between a ulnar claw? What is the basic difference between a ulnar claw versus the pointing index sign? What is the basic difference between an ulnar claw and a pointing index sign? What is the difference? Pointing index sign is seen in median nerve injury. Am I right on that? The median nerve injury, everybody knows that. But the median nerve injury's pointing index sign is only seen when you, as an examiner, ask the patient to flex all the fingers. Right? So when the patient is trying to do so, the fingers, the median nerve supply remains extended. Right, that will be median nerve supply will remain extended. So that is your pointing index finger. On the other hand, if it is a ulnar nerve injury, whenever the patient presents to you in whatsoever attitude, whatsoever time you see him, all the time his finger will be like this. So again the same thing. So this pointing index, the other name for which we call as the Ochsner clasp sign, the other name for which is what you call as the Ochsner clasp sign, or what you call as the Benedict hand sign. What is that Benedict hand sign? Benedict hand is how the Pope greets the people. This is how the Pope greets the people, isn't it? So this is when you as an examiner is checking the patient. When the patient comes to you himself with an ulnar nerve injury, all the time the hand will be like this. These two will always be clawed. You are not asking him to do any movement. So this is always a claw. So ulnar claw will always remain a claw 24 hours of the day. But median nerve injury, the pointing index or the Ochsner clasp or the Benedict hand sign is when you ask the patient to flex the finger. So here, no such history was given. Exactly. So there was no such history, as Dr. Apoptosis is telling us. There was no such history given. So therefore, the best answer that you could have marked is ulnar nerve. No need to go with the exceptional thing. If they say that patient came in OPD, you asked him to flex the finger, and then this was the attitude, that means it's a median nerve injury. So right now, it is a ulnar nerve without any kind of history given to you. Very good. Perfect. Okay. Next one, patient came with pain in the back. Image given below. What is the diagnosis? So what exactly is this? Spondylolisthesis, spondylitis, rheumatoid arthritis, spondylolysis. So what exactly you think it is? The question number 3. What was the answer? What did you mark in this question? So in this question, you can see there are 3 terminologies which I want you to know, understand. Okay. What is the meaning of spondylo? The word spondylo. The word spondylo, it simply means the vertebra. The word spondylo, it simply means the vertebra. Okay. That is a vertebra. Now this spondylo can have associated terminologies with it like listhesis. What is the meaning of listhesis? Listhesis stands for to slip. So when the vertebra slip, we call it listhesis. Or spondylitis. Itis means an inflammatory change. For example, the ankylosing spondylitis, you have heard of that. Enthesitis, right? Ankylosing spondylitis. Then there can be spondylolysis. What is the meaning of lysis? Lysis means a break, a breach, right? That's a break. So where does the break happens? Where the breach happens? It happens at what site? Pars interarticularis. Pars interarticularis. Okay, so you cannot recall this question, but that is what the students have told us, and that's how the team has prepared it. Okay, so pars interarticularis. So there might be some change in the options or some change in the image might be like that. But what was told that the one of the vertebra was slipping over another vertebra. So what is the term that you are going to use if there is a slip of the vertebra? So here you see the sacrum, the L5 is in line. The L5 is this one and this is sacrum. They are in one line. But if you see the L4, L3, L2 like that, they have slipped this much anteriorly. Right? So this is what you call as listhesis, to slip. Listhesis means to slip. So this is slipping of one vertebra over another vertebra. There is a slip of one vertebra over another vertebra. That is what you call a spondylolisthesis. So if this question was there with the same kind of image or some other options, so you know it is spondylolisthesis. Why it cannot be itis? In inflammatory change, you will see fusion of all the anterior margin of all the vertebrae, which is not seen here. In lysis, why it cannot be lysis? Because lysis is a break, or you can say breach, where pars area, the neck of the dog. Remember the neck of the dog. So this spondylolysis is a defect which occurs at pars interarticularis, and this is best visualized in a oblique view. This is best visualized in a oblique view. When you take a oblique view of the vertebra, so remember, listhesis per se will be seen in a lateral view. Listhesis will be seen in a lateral view, and lysis will be seen in a oblique view. Lysis will be seen best in a oblique view. So lysis also can be a question sometime in your exam. So lysis will be best seen in oblique view. The dog is best seen in oblique view only. Okay, that is why. So lysis oblique, listhesis lateral view. Okay, so this one is listhesis. Why it cannot be rheumatoid arthritis? Because in RA, vertebra is not involved. When you read about rheumatoid arthritis, there are 2 joints which are usually not involved in RA. What are those 2 joints? One is the distal IP joint of the hand, this one. These are not involved in RA. Second is the vertebra. And in the vertebra, we have an exception. What is the exception in vertebra? Except for C1 and C2. Except for C1 and C2. So atlantoaxial subluxation can happen, right? But rest of the vertebra is not involved. Reason? What is the logical reason behind that? Because RA, the primary reflection, the primary structure which is affected in RA is what? It is synovitis, the synovium, right? So synovium is getting affected in RA. In osteoarthritis, what you read is the cartilage which is getting destructed, right? So that was the reason. Listhesis would have been the best answer. You can choose out from here. Okay, that was the listhesis. Let's see the next one. A patient met with RTA and had fracture of the shaft of humerus. Okay. After injury, he was unable to dorsiflex the wrist. He was unable to dorsiflex the wrist. That means flexion, extension. So dorsiflexion they are saying, not the palmar flexion. They are saying dorsiflexion. That means upside. They cannot do it. Okay. Orthopedic surgeon advised him a splint as shown in the figure. So when the patient is not able to do the dorsiflexion, what they are pointing to? What they are pointing to? Can you say? If the dorsiflexion of the wrist is not possible, what the examiner, what the question is trying to tell you, that patient is suffering from what? He is suffering from wrist drop. And wrist drop occurs because of which nerve? It occurs because of involvement of the radial nerve. And radial nerve is injured most commonly in which bone's fracture? It is in the fracture shaft of the humerus. Right? That is given to us. So the splint given here is what you call as the cock-up splint. And it is actually a dynamic cock-up splint. The cock-up splint can be of two types. It can be dynamic or it can be a static splint. Now what is the difference in these two? What is the difference in these two? Static. What is the meaning of static? Static simply means that one which is fixed. एक बार आपने लगा दिया तो लगा दिया. That's all. Right? That is static. So static means once you have given the splint, it remains in one position. Like this, or like this. Anyway. Dynamic means what? If you see very clearly, there are springs attached to this. These are the springs which are attached to this. Okay. So spring attached to this, how they help? The patient is having a problem with what? Extension. So this splint, the springs will keep the finger like this. And we will ask the patient to flex the finger, exercise. So flexion part is okay. So he can flex the finger. So he'll be able to flex the finger. Springs will take it back. You flex the finger, the spring takes it back. So the exercise has been taught to the patient so that some sort of muscle atrophy, disuse atrophy can be avoided, right? Exercises can be done, okay? So that's why you call it a dynamic cock-up splint. Knuckle bender splint is used for what? This is one which you used for. This is the knuckle bender splint is what you use for the claw hand. Knuckle bender is what you use for claw hand, okay? Clawing like this. So knuckle bender, bend the knuckles. Where are the knuckles? Here are the knuckles. So you bend the knuckles to get the length for fingers. That is knuckle bender splint. Thomas splint is used to stabilize what? The fracture shaft of the femur. And aeroplane splint, the brachial plexus injury. Remember that? The list that I shared with you guys, right? The brachial plexus, that table that I shared with you. So brachial plexus injury. So aeroplane splint, the brachial plexus injury. Okay. So these are the different types of splints that are to be used in our patients. So there is a big table that I have shared with you already on all the Telegram groups, DBMCI Premier group, my Telegram group. Okay, so you can download, if you have not yet downloaded, just download the table. These are one-liner questions which are very, very important for any of the FMGE exam or any of the IMG exam as well. Image-based questions, these splints, traction systems are being asked in all the exams. Okay, so please download that table. Please download those images. I have given a lot of content, one-liners which are asked as MCQ. So please download that. Okay. Okay. Next one. Right. Okay. So diagnosis in this patient would be, what do you suggest? What is the diagnosis in this patient? So we can see the thumb is over here, the second finger, the third finger, the fourth finger, the little toe. So second and third fingers are connected to each other. What is polydactyly? What is polydactyly? Brachial plexus injury. Very good. Okay. So what is polydactyly? So if you see the terminologies which are telling you about, yeah. Okay. Yeah. Okay. So polydactyly means poly, multiple. So there should be multiple fingers. There should be multiple fingers. So here we don't see multiple fingers. There are only 5 only toes basically. Okay. Syndactyly, when they are together. When they are together. Syn means when they are going together. So syndactyly is the union of one or all the toes. So here the 2 fingers are connected to each other. So we call them the syndactyly. We call them the syndactyly. Yeah, very good. Macro and micro. Dactyle, the toes or the fingers. So macro will be larger one, micro will be the smaller one. So the best answer that you can choose from here, syndactyly, the fused fingers. Very good. Right. So this one is the image which was showing you syndactyly. It's a congenital anomaly. And if the patient is not having any kind of trouble, you leave it as such. Otherwise, some sort of surgery can be done to separate these 2 fingers if required. Okay. What is the fracture pelvis given in the image? So what is the fracture of pelvis given in the image? Open book fracture, or the straddle fracture or the vertical shear fractures. So honestly speaking, I don't see any big major displacement in the bone here. Okay, so let me just frame all the fractures of the pelvis with you. Okay, so if I just draw some rough sketch of the sacrum, the 2, the 3, the 4, the 5 and coccygeal area, and then we have got the ilium here like this, the articulation of head of femur, the ramiz like this, okay. So what are the different types of fractures which I expect you to remember? Okay, what are the different types of injuries? So remember, when there is a fracture of bilaterally both pubic rami like this and like this, when there is a fracture of bilaterally right and left both pubic rami, that is upper rami, lower rami, we call it straddle. So what is straddle fracture? If I say what is straddle fracture, straddle is 1 plus 2. Fracture of bilaterally both pubic rami. The fracture of bilaterally both pubic rami 1 and 2. Okay. Second kind of fracture which I want you to remember is the open book injury. Like this option 2. What is open book injury? When the pelvis opens like a book. When the pelvis opens like a book. So if you want to open something like a book, obviously the posterior side has to have a binding. If I just say this tablet is an open book, so open book means it opens from the front, and from the back side it is okay, it is all right, right? So back side is okay, the sacroiliac joint is okay, but from front the pelvis is opening like a book. So this is what happens when the injury opens up the two pubic symphysis, right? So they are pointing towards this area. Most likely they wanted to point towards this area. So this would have been an open book injury. Most likely, what is the fracture of the pelvis? But we don't see an opening. They have just marked the area. So it could have been a straddle if the image is very much proper. So the image could have been a straddle one, or it could have been a simply the open book injury. So open book injury is number 3. Then there is third kind of injury, the vertical shear or the lateral compression. What is the name they have? One is a Melgagne fracture. We call it what? Melgagne. So what is a Melgagne injury? So open book and straddle, they are anterior injuries only. Open book and the straddle, they are anterior injuries only. Posterior, everything is okay. But when the sacroiliac joint is also damaged, that is number 4, of the same hemipelvis, that means 1 and 4. So Melgagne is injury of the same hemipelvis anteriorly as well as posteriorly. Melgagne is the injury of the same hemipelvis anteriorly as well as posteriorly. Okay, so anterior injury as well as the posterior injury of what? Of the same hemipelvis, that is 1 and 4. And when the injury is on opposite hemipelvis, we call it bucket handle injury. We call it bucket handle injury. So what is that bucket handle injury? When the injury occurs on opposite side, like for example 2 and 4. So anteriorly and posteriorly. Anteriorly left side and posteriorly right side. So 2 and 4. So bucket handle injury. Okay, so these are the types of injuries which I want you to remember. So most likely they were trying to point on open book injury or maybe the straddle fracture, most likely. So whatever it was, so now I have told you all the 4 different fractures. Okay, next question was, a person sitting in the front seat of the car met with a road traffic accident. Following injury, his limb was in flexion, adduction and internal rotation. Feather. X-ray was done as shown in the figure, most likely diagnosis. Okay, so again I'm saying, guys, those who are active with me on any of the social media network like Facebook or on the Telegram of DBMCI or my group, so you have one handwritten note that I have just noted down some points, some conditions, and in what condition, what is the attitude of the hip. I have already given that on the groups. Please download that also. Some 7-8 conditions are there. For example, how the attitude is in tuberculosis, how the attitude is in fracture neck femur, how in IT, how in Perthes, how in SCFE, how in dislocations. So that will help you out to, memorize the things in a short span of time. Okay. So here what we are having, the flexion, adduction and internal rotation. So if we are talking about different types of dislocations in the neck femur, shaft femur. So whenever there is a dislocation, anterior dislocation means the head. If you talk of my right hip, right acetabulum, right head of femur, the head is to go anteriorly. That means in the external rotation, correct? And if there is a posterior dislocation, the head is to go back. That means in internal rotation. So here what we are having, internal rotation. Yes, absolutely. Apoptosis, Khushbu, Alia, B, everybody is right that it has to be a posterior dislocation of the hip only. This has been a question of your All India exam also this time, INI exam also this time, and in FMGE also this time. So few topics are very, very important, and you as an exam going student should be able to analyze that what is most important for me or what is somewhat not that important for me. right? When you revise it, that thing should be on your tips, that which is more important, shaft of femur or neck of femur? Obviously neck of femur, right? So you should be able to analyze your content, what part is more important, what part is not that important. Okay, so that was your question number 7. So this is posterior dislocation. Again, I'm reminding, please download that image. The handmade note is there. Note down in your notebooks, right? Note down in your notebooks. Okay, so that will be very, very Faber anterior dislocation. Very good, Alia. Perfect. Perfect. Okay. Next one. Sir, NEET also similar question. Exactly, Khushbu. That is what I said. In NEET also there was a similar question which was asked. You are right. Absolutely right. Name the test being shown below in image. So basically this was a question which was told like that the patient was asked to flex all the fingers and the finger remain extended. Now I am not very much sure whether both the injury questions were there about the ulnar nerve as well as the median nerve, but if it was there, then you know what it is. It is a pointing index sign. You know this very well. So this is what you call as pointing index sign. So if you guys can confirm if both the questions were there, good. So this is what you call pointing index sign. So test shown in the image is a pointing index sign. So if both the questions were given to you in the exam, well and good. If not, then you know how to select one. So pointing index is when you ask the patient to check it. When the patient himself comes to you like this, that's a ulnar nerve injury. Okay, that will be a ulnar nerve injury. Next one, what was that? Okay, identify the tumor in the image. Identify the tumor given in the image. So what do you think it was? Was it a giant cell tumor? Was it an osteoblastoma, Ewing sarcoma, unicameral bone cyst? Now this tumor is the one which has been asked in all the previous 5 or 6 sessions of the exam, whether it is an INI or whether it is your All India exam, right? हर exam में ये question पूछा गया है, हर exam के अंदर. So what we are dealing with, string tied to index finger. Okay. A, giant cell tumor. It was GCT. So all the time, if you have been with me when I am discussing tumors, then I have always told you that the first thing to be seen in any tumor will be the location. If you want to decide that what probably this tumor can be, the first one has to be, Alia, I would like to just say that all the time when you are talking about the tumors, the first thing to be seen is the location. Now this is a epiphyseal location. So at epiphyseal, you should be able to recall that we have 2 options, osteoclastoma and chondroblastoma. And then you want to know the nature of the lesion, and third, the special feature. So we never see the so bubble and we say it is GCT. No. This similar kind of septations can be a part of ABC also, but then that will be metaphyseal. Okay, so all the time you should be able to analyze the location of the lesion first. So always see what is the location of the lesion. Always see what is the location of the lesion. So it is epiphyseal. Answer has to be from these 2. And the special feature, you know, the age group for giant cell tumor, it has to be 20 to 40 years. Nature, it is a locally aggressive tumor. It doesn't usually show metastasis, right? Locally aggressive tumor, or the special feature that you're telling about, everybody telling classic soap bubble given in the exam. So that's fantastic. But the soap bubble, you should always analyze that the soap bubble must be in a skeletally mature patient. The age group for ABC will be a skeletally immature patient, 10 to 15 to 20 to 25. But giant cell tumor, 20 to 40. Skeletally mature patients. So again, for this also, I have given you one hand-drawn image with all their special features in the tumors. Find that group and join it and just download all the important stuff that you have for you. Right? The tumors, the deformities and all these things will be very, very much important. Okay, let's see. A patient was diagnosed as a case of supraspinatus tendinitis. Very good. What degree and what movement of shoulder would be painful? Now, what we are dealing with is a supraspinatus tendinitis. And we know that supraspinatus tendinitis is a reason for what condition? Can you name that? What was that condition with which it is related to? The supraspinatus tendinitis, it will be connected to or will be a reason for what we call as the painful arc syndrome, isn't it? The painful arc syndrome. What is that painful arc? When I try to abduct my arm, no pain, and no pain, and now this is painful, this is painful, this is painful, this is painful, all painful, and now the pain disappears. This all is okay. So pain during mid-range. What mid-range? It is 60 to 120 degrees. So pain during mid-range of abduction is 60 to 120 degrees. And what are the primary reasons for that? The painful arc syndrome. Painful arc syndrome, the primary range is 60 to 120, and the reason, the most common culprit is supraspinatus. The most common culprit is supraspinatus. Right? The most common culprit will be supraspinatus. What all can happen in the supraspinatus? What all can happen to the supraspinatus? The supraspinatus can have a tendinitis. The supraspinatus can have the calcification. So tendinitis, calcification, or when there is a partial tear. When there is a partial tear. So tendinitis, calcification and partial tear. So do remember, it is never about the complete tear, because if there is a complete tear, there won't be any abduction at all. 0 to 15 degrees abduction is by supraspinatus. That won't be possible. But if it is a partial tear, if it is a calcification, if it is a tendinitis, what will happen? When we abduct our arm, when we abduct our shoulder, जैसे जैसे आप ऊपर करोगे, the clavicle here and the acromion here, in between them, what do we have? The coracoacromial ligament, right? So when the inflamed part, when the tendinitis part, the calcified part, it passes under the tunnel, it will cause pain. And after 120, it will just cross the tunnel. So this is the area under which the inflamed fragment goes, and that causes pain. That is your painful arc syndrome. So supraspinatus tendinitis, supraspinatus calcification, or supraspinatus partial tear. Other reason can be subacromial bursitis. Other reason can be subacromial bursitis. And third reason can be the fracture of the greater tuberosity of the humerus. Okay, so this is painful arc syndrome. Now from shoulder, guys, what I want you to remember, see, shoulder में जब भी problem होगी, तो movements, different types of movements will be restricted. For example, if it is painful arc, it will be midway, right? If it is a frozen shoulder, it starts with internal rotation. You ask the patient to keep the hand on the lower back, he won't be able to do it. That is, the internal rotation will be affected. Okay, if the complete arthritis has happened, global restriction of the movement. Okay, if there is a tear of some of the rotator cuff muscle, then obviously the concerned muscle's movement will be hampered. For example, supraspinatus 0 to 15. For example, infraspinatus external rotation, teres minor external rotation, subscapularis internal rotation. So only one movement will be affected. So always remember that how the movements are affected in different injuries of the shoulder. Okay. Right. Okay. So what did you mark for this? Sunlight causes conversion. Sunlight causes conversion of which of the reaction is happening because of sunlight. So this is a vitamin D cycle basically. Okay. Yeah. So sunlight, how does it help? How does it help? The level, basically the 7-dehydrocholesterol, it is broken into multiple fragments into its exposure, the D isomers we say, and it happens because of the ultraviolet exposure, the ultraviolet light B usually. Okay, so this is a vitamin D cycle. Your basic about the how vitamin D gets activated in our body, the inactive form, how it works in the bones, how it works in the liver, how it works in the intestine, in the kidneys, all the areas. So it is a sunlight which helps in conversion of, it is a sunlight which helps in conversion of the inactive form, that is 7-dehydrocholesterol to cholecalciferol, by when the ultraviolet lights, the usually B type, when they fall on our skin. Okay, so these were some of the questions, guys. What my message to all of you is very, very simple. Please stick to the basics. If you have done well the FMG examination, fantastic. If when you are preparing for the NEET exam next time, go with the basics. Basics are the crux of any of the subject. And you will see that whatever exam it is, whether it is INI, whether it is NEET or whatever, basics will play the major role. Concepts are going to play the major role. So don't try to mug up the things. If you will mug up, you will end up in trouble. I'm pretty much sure about it. So remember the basics in your mind, remember the concepts in your mind, and believe me, answers will come automatically to you. Okay, so we don't have to mug up all the time that GCT is so bubble, GCT is so bubble. At what part? Concept. What is the difference in GCT and ABC? How will you differentiate? Right? So conceptual thing has to be in our mind, that how I need to label GCT. If instead of GCT they give you some other maybe chondroblastoma, how will you come to know? So if you remember the basics only, simple basics, what tumor at what location, what nature and what special feature, it is easy for us. And believe me, nobody is interested in asking you the hi-fi things. Everybody is testing your basic knowledge. Right? Only it is a game of words, and you have to solve that simple puzzle. And if you can do it, I think all the answers in any of the exam, you can crack it. Okay, so in medical world, we have only two types of things for a student, factual and conceptual. And all the facts, they lead to some kind of concept. So facts have to be remembered, concept have to be taken out from the facts only. Okay, so stick to the basics, stick to the concepts, and I am pretty much sure you are going to do well with the results. We are hoping the results are coming very, very soon. My best wishes to all of you guys, right? I hope and I pray that all of you just pass the exam, and we can see you and we can meet you very, very soon after that, so that we can just plan our next step. Okay, so Telegram group will be either DBMCI Premier group, or you can search the Sushil Orthopedic Discussion group. Both are available, so you can join and you can take out the orthopedic content. Okay, so all the very best, guys. Do let me know about your results. I'll be waiting to hear from you. All the very best, and thank you so much.